Welcome to The Explainer. Today, we're taking a super frustrating medical diagnosis and turning it into a totally solvable mechanical mystery. If you're a runner or if you treat runners, you already know that knee pain can feel like an absolute roadblock. But today, we're going to look at the actual science of the kinetic chain. We want to understand exactly why these breakdowns happen in the first place, and much more importantly, how you can structurally fix them. So let's dive right into this mystery with a question that might sound absolutely crazy if you're currently sitting there icing an aching kneecap. Why does your knee hurt when the real problem is actually up in your hip or even down in your foot? It turns out focusing solely on the spot that hurts is often exactly why these chronic injuries just stick around forever. Check this out, because it brilliantly illustrates why we need to completely rethink recovery. A massive 80% of running clinic visits are for overuse injuries, right? So unlike acute injuries, like say rolling your ankle on a route during a trail run, these overuse injuries stem from repetitive, submaximal loading combined with just a lack of tissue recovery. It causes this microtrauma right down at the cellular level. Because of that, the actual root cause of the injury is rarely where the pain ends up showing up. Let's formally introduce today's victim, runner's knee, or, as it's clinically known, patellofemoral pain syndrome, or PFPS. If you've had it, you know it. It presents as this diffuse, annoying pain right behind or around your kneecap, especially when you're squatting, running, or walking downstairs. Basically, it's what happens when your kneecap gets pulled laterally right out of its trochlear groove because your leg keeps collapsing inward. Here's where things get really interesting. We are completely tossing out the old rest and ice playbook. That historical paradigm of total rest, it's actually been discredited by modern sports science. Prolonged immobilization just leads to tendon atrophy, muscle weakness, and even decreased bone density. No thanks. The new way relies on controlled mechanical loading. We use targeted resistance to actually stimulate cellular adaptation. We literally have to put load through the tissue to build its capacity back up. Section 1. Anatomy of a collapse, focusing on the kinetic chain. The crucial takeaway here is that your knee is usually just the victim. Think of the knee as a kind of dumb hinge. It's just caught in the middle between two highly mobile, incredibly important joints, your hip and your ankle. When those joints get lazy and fail to do their jobs, your poor knee takes all the punishment. Running happens mostly in a straight line, but if you lack lateral stability, your whole form just falls apart. It's a complete chain reaction, and the systemic collapse starts far away from the knee itself. Often, weak side hips let the pelvis drop on one side. At the exact same time, poor intrinsic foot control might let your midfoot arch roll inward. Because of that excessive pronation at the foot and the drop up at the hip, your thigh and shin rapidly twist inward. This forces an inward knee collapse. The clinical term is dynamic valgus. That is literally grinding the cartilage of your kneecap away with every single stride. Ouch. All right, part 2, fix number 1, the Spanish squat, targeting that patellar pain. Here is the absolute secret sauce for setup. You anchor a thick, heavy loop band to a stable post. Step inside it so the band rests right behind your knees on the upper shin, and you lean back until that band is perfectly taut. From there, you squat down, but you have to maintain completely vertical shins. The clinical protocol we're looking at here starts with 5 sets of 45-second isometric holds. It's literally a brilliant mechanics hack. It lets you completely blast your quad muscles without grinding the kneecap against the joint. Because you're leaning back with vertical shins, the band's posterior pull actually reduces those patellofemoral compression forces. Plus, doing this as a heavy isometric hold produces what's called an acute analgesic effect. That means it acts as an instant pain reliever by modulating your central nervous system, which beautifully prepares your legs for more activity. Moving up the chain to section 3, fix number 2, the lateral band walk, focusing on fixing that hip drop. The setup for this one is absolutely key. Place a loop resistance band around your ankles and stand on a single leg. You want to keep that stance knee slightly bent and the pelvis totally perfectly level. Then you step the other foot outward to a 30-degree angle. The goal is to control the movement entirely at the hip without tilting your upper body over to compensate. By building up those side hips, your gluteus medius specifically, you're basically installing tight suspension cables. These cables stop your pelvis from dropping on the swing leg side. And here's the magic. When you prevent that pelvic drop, you stop the thigh from rotating inward, which keeps your knee tracking perfectly straight with every single stride. It directly addresses the friction and that dynamic valgus causing your runner's knee in the first place. Down to the floor for section 4, fix number 3, balance, and securing your foundation. I know, it sounds almost too simple, right? But the clinical execution here makes literally all the difference. First off, doing this barefoot is mandatory. You stand on one leg and actively grip the floor with your toes. This forces your foot into active work, and you hold it for 30 seconds per side. Think of it as a dynamic pre-run activation routine designed specifically to wake up your stabilizers. This active balance training forces your tiny intrinsic foot muscles to finally fire up. A stronger foot improves your shock absorption and stops your medial arch from just aggressively collapsing mid-stride. And remember that chain reaction we talked about earlier? If the arch doesn't collapse inward, it doesn't drag the tibia and the knee inward with it. You are totally securing your structural foundation. Finally, Section 5, the golden rule, the pain monitoring model. To build a safe recovery roadmap, we use the standard pain monitoring model. It classifies your activities based on your physiological response. For light loading, like our isometric Spanish squats, an acceptable pain level is a 2 out of 10, and you can actually do those daily. For medium resistance loading, a 2 or 3 out of 10 is totally fine, but you'll need 48 hours to recover. And for heavy resistance, you might even hit a 4 or 5 out of 10 on the pain scale, but then you'll need 72 hours of recovery. The big takeaway? Low-level discomfort is actually acceptable and necessary to remodel the tissue. Now, you do have to balance that acceptable discomfort with a few hard and fast clinical soreness rules so you don't overdo it. The ultimate rule is the 24-hour rule. Any pain you experience during these exercises absolutely must return to its baseline level by the next morning. If it doesn't, you need to back off. Also, if pain ever alters your running stride or if it keeps you awake at night, stop immediately. Following these guidelines guarantees you're actually healing your tissues rather than just re-injuring them. So, I want to leave you with this final provocative question to think about as you evaluate your own training and mechanics. When treating an injury, are you merely resting the victim, or are you actually fixing the culprit? Ditching the passive rest for active loading and treating the full kinetic chain from your hips all the way down to your feet is how you truly resolve runner's knee for good. Take control of your kinetic chain, and I'll catch you on the next explainer.